For decades, the loudest, most persistent medical advice you have probably heard is to check yourself regularly for lumps. I mean, it was plastered on pamphlets in every doctor's waiting room.
Right, yeah, like do a monthly exam in the shower, know your tissue.
Exactly. But what if I told you the absolute newest clinical data says that, well, doing exactly that might actually cause you more harm than good?
I know, it completely flips the script on what we thought preventive medicine looked like.
Welcome to the Deep Dive, customized specifically for you, a resident learner. Today we have this really comprehensive medical review document on our desk. It details the modern strategies, the biology, and the surprisingly intense debates surrounding breast cancer screening.
Yeah, and the big picture here is, at its core, a massive success story, right? Breast cancer remains the second most frequent cause of cancer death in U.S. females, but the mortality rate has absolutely plummeted since the 1980s.
It's a dramatic drop. And the medical community credits that decline to a powerful combination of two things. So significantly better, more targeted treatments, and earlier detection through organized screening programs.
Right. Early detection saves lives. It's the ultimate medical slogan.
Oh, absolutely. But when you look closely at the actual clinical guidelines, like the rules dictating exactly who gets screened, when they start, and what machines are used, it is incredibly murky.
Very much so.
The major medical societies just completely disagree with each other. Okay, let's unpack this. Our mission for today's deep dive is to decode this rule book. We want to cut through the conflicting recommendations and equip you with the actual why and how behind the science.
Yeah, so you can navigate your own health decisions without feeling completely lost in the data.
Right.
And to get to that why, we really have to start at the very beginning of the patient experience. Before you ever step in front of an imaging machine, a doctor has to decide if you're actually in danger. They have to calculate your risk. And the math we use to predict cancer risk is, well, it's shockingly flawed.
Really? Because I noticed the source document divides everyone into 3 lifetime risk categories. There's average risk, which means a lifetime probability of less than 15%. Moderate risk, which sits between 15 and 20%, and high risk, which is anything over 20%.
Right.
And obviously, the first thing everyone thinks about when they hear high risk is genetics, like the BRCA mutations.
Oh, for sure. The BRCA1 and BRCA2 genes make all the headlines, and for a very good biological reason. If a patient has a BRCA1 mutation, their absolute risk of developing breast cancer by age 70 is nearly 60%.
That is a staggering number.
It does.
But the text highlights a really strange paradox here.
It does. What's fascinating here is those specific genetic mutations are incredibly rare in the general population. We're talking about maybe 1 in 300 to 1 in 500 people carrying them.
Wow, that rare.
Yeah. So while the individual danger is massive, those genetic markers only account for about 5 to 10% of all breast cancer cases.
Which means the vast majority of people who develop breast cancer do not have a blaring genetic red flag.
Exactly.
Those people fall straight into that average risk category, carrying a baseline 12.4% lifetime risk. So if we don't have genetics to rely on, how do doctors figure out who is actually going to get sick?
They turn to clinical prediction tools. They feed a bunch of your personal data, like the age you started menstruating, your family history, your breast density, into an algorithm. The most common one is called the Gale model, or the breast cancer risk assessment tool.
Okay, and here's where the math really confused me. The source document says that if we use the Gale model to designate someone as high risk over a 5-year period, it has a sensitivity of only 28 to 44%.
Right.
And a specificity of 66 to 88%. Let's pause right there. Break that down for me. What do sensitivity and specificity actually mean in plain English?
Sure. So think of sensitivity as the algorithm's ability to catch the true threats. If 100 people are definitely going to get cancer, a sensitivity of, say, 28 to 44% means the model completely misses more than half of them.
Wow.
Yeah, it tells them they are perfectly fine when they actually aren't.
That is terrifying. Okay, so what about specificity then?
Specificity is the model's ability to ignore the noise, right? To correctly identify the people who are truly safe.
Got it.
So a specificity of 66% means it's falsely flagging a huge chunk of perfectly healthy people, just telling them they are at high risk when they're actually fine.
Wait, if I had a weather app that only correctly predicted rain 30% of the time it actually rains, I'm deleting that app.
Right, you'd never trust it.
Why do doctors use a prediction tool with such massive overlap between people who do and don't get sick?
It's It's not a failure of the statisticians, it's more of a limitation of human biology. To build a highly accurate prediction model, you need incredibly strong variables. You need a data point that screams, this means cancer. But outside of those rare genetic mutations, we simply haven't discovered those strong predictive factors for the average person yet. Things like the age you hit puberty or having an aunt with breast cancer are only moderately predictive. They whisper, they don't scream.
So if the individualized math is fundamentally broken, what do? We have to base these massive national screening guidelines on something.
Because we lack a perfect crystal ball for the individual, the medical community relies on the ultimate, albeit imperfect, proxy for risk, which is age. Breast cancer incidence is highly correlated with simply getting older.
Which brings us to the most hotly debated topic in all of preventive medicine, the timeline.
Oh, yeah.
If we're using age as our trigger, when exactly are we supposed to start looking? Because if you look at the under 40 crowd, the guidelines are unanimous. Do not routinely screen them.
Right. The incidence of the disease in women under 40 is quite low. But beyond that, the tests themselves physically struggle to perform well in younger tissue. Let's look at the raw data from a massive study highlighted in the text. Researchers looked at over 73,000 initial screening mammograms performed on females between the ages of 35 and 39. The positive predictive value was only 1.3%.
Okay, another statistical term. Positive predictive value. Does that mean out of all the alarming scans they found, only 1.3% were actually cancer?
That is exactly what it means.
I have to push back here. I mean, I know I'm supposed to look at this rationally, but breast cancer is a leading cause of death.
Sure.
Instinctively, as a patient, wouldn't I want to be screened at 20? Isn't more information always better, even if the positive predictive value is only 1.3%? Finding that one single case of cancer seems worth it.
It's the most natural human reaction to have. We view screening as inherently harmless.
Right, you take a picture, you get peace of mind.
Exactly. But we have to translate that 1.3% into the real world. It means 98.7% of the abnormal findings in that age group were false alarms.
Nearly 99%. That's huge.
Yes. And a false alarm in cancer screening is not just a harmless oops, it's a cascade of medical interventions.
What do you mean?
Well, it means the radiologist sees a shadow. Then you're called back for more imaging. You sit in a waiting room consumed by anxiety thinking you might die.
Oh, wow, yeah.
Then comes an invasive biopsy where a doctor literally inserts a hollow needle or a scalpel into your breast tissue to extract cells. You endure physical pain, financial cost, and emotional trauma.
All for a lump that turns out to be completely benign.
Exactly. The medical community calls these harms. And under age 40, the sheer volume of these very real harms vastly outweighs the microscopic chance of finding a lethal tumor.
That reframes it entirely. The cost of looking is just too high for the amount of finding you actually do. But if the math is so terrible for younger people, what happens when you cross into your 40s? It seems like this is where the major medical societies just throw their hands up.
Yeah, the 40 to 49 age bracket is the grayest of gray areas.
I mean, the U.S. Preventive Services Task Force says you should start screening every 2 years at age 40. But the American Cancer Society says start annual screening at 45. Why the split?
It comes down to how different groups weigh a very small benefit. A major meta-analysis in the source shows that if you screen 10,000 females over 10 years in their 40s, you prevent about 3 breast cancer deaths.
Wait, 3 deaths prevented out of 10,000 people screened for a decade.
Yeah. When you hear the absolute numbers rather than relative percentages, you see the dilemma. Some international groups refuse to mandate screening in the 40s at all, recommending shared decision-making instead.
Right.
If you're sitting in your doctor's office in your early 40s, you aren't just checking a generic medical box. You are personally weighing the prevention of those 3 tragic deaths against the absolute certainty of thousands of false positives and unnecessary biopsies in your peer group.
But then you turn 50. And from age 50 to 74, suddenly every medical guideline perfectly aligns. Everyone agrees this is the sweet spot where screening definitively saves lives.
They do.
Why does turning 50 magically make the machines work better? What's physically happening inside the body?
It's a profound biological shift. Before menopause, breasts are filled with dense glandular tissue. That's the tissue responsible for producing milk.
Right.
But after menopause, that glandular tissue slowly begins to break down and is replaced by fat.
Oh, interesting.
And on an X-ray, glandular tissue is white and opaque. It makes it incredibly hard to see through. But fat shows up dark and transparent.
So as the breast tissue becomes fattier in the 50s and 60s, a mammogram becomes a dramatically more effective window.
It's like the fog finally lifts.
Beautifully put.
The incidence of the disease is higher in this age group, and our tools can finally see clearly. The data shows a 33% relative risk reduction for mortality for those aged 60 to 69 who get screened.
Wait, let's clarify that, because 33% sounds massive.
Yeah.
But we're talking about relative risk, right?
Correct. Relative risk reduction can sound much more dramatic than absolute numbers. If your absolute risk of dying from breast cancer in that decade was, say, 3 in 1,000, a 33% relative reduction means your risk drops from 3 in 1,000 down to 2 in 1,000.
Okay, I see.
It is a profound life-saving difference for that one person, but the absolute numbers keep the population statistics in perspective. The benefits here clearly outpace the harms of false positives.
But the guidelines don't tell you to screen forever. Once a patient hits 75, the rules take a really surprising turn. They suggest only offering screening if the person's life expectancy is at least 10 years.
This introduces one of the most counterintuitive concepts in medicine, which is overdiagnosis.
The idea of finding a cancer that wouldn't have actually hurt you. Explain how that's biologically possible. Because, we're taught that all cancer is a ticking time bomb.
We treat the word cancer as a monolith, but behaviorally, tumors are wildly different.
Okay.
Some are absolutely ticking time bombs, but others are more like a turtle. They're growing so incredibly slowly that they might take 15 or 20 years to pose a threat.
So, they might never actually become a problem.
Right. A common example in the text is ductal carcinoma in situ, or DCIS.
Okay, DCIS.
In situ means the abnormal cells are confined strictly inside the milk duct. They haven't invaded surrounding tissue.
So if a patient is, say, 82, and they have a heart condition that might limit their life expectancy to 5 years.
Finding that turtle cancer just doesn't help them. The cancer won't be the thing that ends their life. Their heart will.
But the moment you spot that slow-growing DCIS on a mammogram, you can't unsee it.
Exactly. The patient is immediately subjected to the stress of a cancer diagnosis. They might undergo surgery or radiation. You've drastically decreased the quality of their final years without extending their life by a single day.
That is a heavy, incredibly complex equation. Knowing when to screen clearly relies on understanding the biology of aging. But what about how we screen?
Yeah, the methods.
If the math tells us to wait until our 50s, that puts a massive amount of pressure on the actual scanning machines to be perfect.
And spoiler alert, they aren't perfect.
According to the source, mammography, whether it's standard digital 2D or the newer 3D tomosynthesis, is the undisputed champion. It's the only imaging technique proven in randomized trials to decrease breast cancer mortality in average-risk populations.
All right.
But the text also notes it misses up to 20% of underlying breast cancers.
A 20% blind spot is significant.
Which begs the question, why don't we use better technology? The source mentions ultrasounds and MRI scans, but strictly forbids using them as routine screening tools for average-risk females.
Yes.
If an MRI takes a much more detailed picture, why aren't we all getting MRIs?
Because more detail isn't always better. Sometimes it's just more confusing. Using an MRI for an average-risk person is like setting your home security system so sensitively that it triggers a deafening alarm every time a shadow moves across the window.
Or a leaf blows past the porch.
Exactly. You'll go crazy responding to alarms when there are no burglars.
Because the MRI lights up blood flow.
Right. Precisely. Perfectly normal hormonal changes in the breast increase blood flow, and the MRI lights that up like a Christmas tree. You end up biopsying totally normal tissue, bankrupting the healthcare system, and traumatizing the patient.
Wow.
MRIs are reserved solely for that high-risk group we discussed earlier. The BRCA carriers whose baseline danger actually justifies the hypersensitive alarm system.
Okay, so mammograms are the flawed gold standard. But this next part truly threw me. The guideline stance on physical breast examinations.
Oh, this is a big one.
Here's where it gets really interesting. Like I mentioned at the top of the show. For decades, the mantra was, check yourself.
Right.
Do a systematic breast self-exam, or BSE, every single month. Feel for lumps. Are these guidelines actually telling you not to look for lumps?
If we connect this to the bigger picture, it is a massive paradigm shift. The medical community is officially shifting the burden of detection away from the patient and relying strictly on the clinical data.
What does the data actually say about the self-exam?
It says that routine, scheduled, methodical breast self-exams by average-risk individuals do not decrease breast cancer mortality. Let me be unequivocally clear on that. Large-scale studies show they do not save lives.
How is that even possible? I mean, if you feel a lump, shouldn't that lead to an early catch?
Because human fingers are not highly calibrated medical instruments, what the methodical self-exams do produce is a staggering volume of false positives.
More false alarms.
Exactly. Patients find completely normal, benign cysts or lumpy glandular tissue, panic, and rush to the doctor. It leads directly to that cascade of harms we discussed: extreme anxiety, unnecessary imaging, and benign biopsies.
The source even mentions that clinical breast exams where a doctor physically checks you during an annual well visit are generally not recommended as a standalone screening tool in the U.S. for the exact same reason.
The World Health Organization only recommends physical exams in low-resource settings where mammography simply isn't available. Now, a crucial caveat here: the medical community still wants you to maintain breast awareness. If you randomly notice a sudden change, like a new distinct lump, skin dimpling, nipple discharge, you absolutely must report that to a doctor.
But the scheduled, anxious hunting for lumps in the shower.
The data says to let it go.
So mammography is the imperfect but singular champion. The final piece of the puzzle is deciding how often we put ourselves through that machine. The timing debate, annual versus biennial.
Right, every year or every 2 years.
Once again, the guidelines for average risk females are totally split.
Yes, they are.
But the data comparing the two approaches is fascinating. The absolute difference in saving lives between getting a mammogram every year versus every 2 years is incredibly small.
Very small.
However, the harms scale drastically with frequency. The source cites an observational study looking over a 10-year period. If you get screened every single year for a decade, your cumulative chance of having a false positive mammogram is 61%.
More than half of the women screened annually will experience a false alarm.
But if you shift to going every 2 years, that rate drops to 42%. And the rate of unnecessary biopsies drops from 7% down to 5%.
Exactly.
It feels like deciding whether to change your car's engine oil every 3,000 miles or 10,000 miles. Instinctively, you think doing it more often is safer. But the data says the engine is fine, and you're mostly just paying for unnecessary mechanic visits and panicking over dashboard lights that don't actually mean anything.
That analogy hits the nail on the head. You're exposing yourself to double the anxiety and double the false alarms for a microscopic sliver of extra protection. But of course, human biology isn't a factory-made car engine. We have to add a layer of nuance.
Because everyone's tissue is different.
Yeah.
So what tilts the scale toward needing an annual scan?
The biggest variable mentioned in the source is breast density. Remember earlier when we talked about how fat replaces glandular tissue as we age?
Right, the fat is dark on the X-ray, the glandular tissue is white.
Well, tumors also show up white on an X-ray. So looking for a white tumor in a dense, highly glandular breast is like looking for a snowball in a blizzard.
Oh, that makes sense.
Because the mammogram is already physically struggling to see through that dense tissue, checking more frequently annually gives the radiologist a better chance of catching subtle changes as a tumor grows.
But if a patient is older and their tissue is primarily fatty,
that same tumor would stand out starkly, like a snowball on a black asphalt road. For those patients, some modeling studies in the text suggest they might even be able to safely go 3 years between screenings.
So what does this all mean? We started this deep dive looking for clean rules, like a simple checklist for how to handle breast cancer screening.
And we definitely didn't find one.
Not at all. The sheer number of variables, your age, your breast density, the wildly imperfect risk models, the biology of slow-growing tumors, proves that there's no universal checklist. For the average risk person, screening is a high-stakes balancing act.
It really is.
It requires sitting down with a doctor, engaging in true shared decision-making, and weighing the very real, proven benefits of saving your life against the statistically significant risks of false positives, emotional trauma, and overdiagnosis.
It's a profound conversation about your unique biology and your personal tolerance for risk. But as we wrap up, I want to leave you with a thought that builds on a tiny detail hidden near the very end of the source material.
Okay, what is it?
The text briefly mentions the emergence of machine learning algorithms, artificial intelligence, that are beginning to incorporate mammographic imaging data directly into risk prediction.
Oh, wow. Using AI to analyze the X-rays themselves.
Think about the implications. Right now, our risk models, like the Gale model, are mathematically flawed because they rely on weak human variables, and we're forced to use age as a blunt, imperfect proxy. But what happens when an AI can look at the very first mammogram you ever get at age 40? What happens when it can analyze millions of microscopic textural data points about your specific tissue structure patterns the human eye can't even perceive and calculate your exact, highly personalized biological timeline?
It would completely change the math.
Exactly. Will AI eventually remove that shared decision-making element entirely? Will it eliminate the stressful gray area of our 40s, telling us with absolute mathematical certainty exactly the day our individual screening should begin and exactly the day it's safe to stop? It's something fascinating to ponder the next time you step into the clinic and look at that machine.
It really is. Suddenly, that murky diagnostic landscape we talked about at the beginning of the show might get cleared up after all, not by using a simpler algorithm, but by using one that is unimaginably smarter. Thank you for joining us on this deep dive. Keep asking those hard questions, keep looking past the simple answers, and stay curious about your own health data. We will catch you next time.